Hello and good morning or good afternoon, depending on where you are. My name is Herbert Riley, and I would like to welcome you to our fourth session of our 8-part Every Step of the Way Through the 1000-Day series. We value your time here, and we hope you leave here today with some new insights and eager to advance continuity of care in your community. Thank you for those who responded to these polls. Thanks for introducing yourself in the chat box if you choose to do so. So this series and our project is funded by CDC, the Division of Nutrition, Physical Activity, and Obesity, but the views within the blueprint in this webinar does not necessarily represent those of CDC. We also want to acknowledge that the content in the blueprint is a result of inputs from over 100 individuals in the field. And finally, we want to state that today's presenters have no conflict of interest to declare. Mommy, one of the speakers, was selected as a consultant for the Blueprint Recommendation 3, and they will share their organization disclosure in their presentation. Here's our continuing education information. By watching this session live or recording, you are eligible to receive all discontinued education credits and SERPs are pending approval. This series is accredited by CDC and meets the quality training standards. Stay put, we'll share more information on how to claim these credits at the end of the webinar. So here's our agenda for today. I'm very excited to hear from this amazing panel of such smart and highly experienced clinical and public health professionals. I am going to kick us off by providing a background on recommendation 3. Then we'll turn it over to Linda Hanna from MAMI and Dawana Brown from Help Me Grow within the DC Health Department. And then we'll talk about care coordination. They will talk about care coordination and their digital perinatal implementation in DC. Next, you hear from one of our Rockstars Blueprint partner grantees, Dr. Julie Ware from Cincinnati, who is partnering with Hamilton County Public Health, here represented by Jamaica. They're going to address, and then we are going to address all the questions in the end of the webinar during the Q&A session. So please chat your questions and comments throughout the webinar using the Q&A box. We will be closing the chat box soon. The Q&A will be open, but we'll close the chat box soon so you can focus on the content that the speakers prepared to share with you today. So as you see, all the speakers have contributed to advanced continuity of care. So you can see all their bios and the bio sheet that we uploaded in the Blueprint website. So here's a little bit about us. NACCHO is the National Association of County and City Health Officials, and our mission is to advance the work of local health departments and its community partners to create healthy, thriving communities. We have several different programs at NACCHO to help advance our mission. Within NACCHO, we are the CHEST breastfeeding program and under the maternal, child, and adolescent health portfolio. Currently, we are in the 4th year of the Reducing Breastfeeding Disparities Through Continuity of Care project. For the past 7 years, we have assisted over 100 communities to implement local level lactation support programs, and we have developed many resources, tools, and grantee stories. Most recently, we launched the Continuity of Care in Breastfeeding Support Blueprint. Currently, we have our first cohort of 10 grantees implementing the blueprint with partners. Our team also provides technical assistance to the CDC REACH recipients that are working to advance continuity of care in their communities. You can visit our website to learn more. So let's just do a very quick recap of the 8-part series. Each webinar is focused on one of the 7 recommendations in the blueprint. Today is the 4th webinar. Our first webinar was in August, which was the big launch of the blueprint. Then we provided a rationale, an overview of the blueprint, and then the 2-year background process that took place before the launch. Then in November, we had our webinar on recommendation 1, discussing the critical role of breastfeeding as a community health improvement strategy and as a matter of food security. Then most recent, in February, we had a webinar on recommendation 2, where we discussed the breastfeeding policy systems and environmental solutions to make sure all spaces within a community are supportive of CHEST breastfeeding. Anyways, today's topic is recommendation 3, lactation care coordination, and later in the year and next year, we'll have the rest of the series focusing on lactation training, local breastfeeding data, family-centered care, CHEST breastfeeding social determinants of health, and health advocacy and CHEST breastfeeding champions. So stay tuned, there's a lot more coming. So before we get started, let me hear about some of your personal and professional experience in this area. I'm gonna ask you some questions and please answer by typing yes or no in the chat box. So first, have you ever heard from your client that their doctor told them a very different infant feeding advice than yours?
Yes, I see you on there.
Okay, I'm here.
Now I'll ask the other speakers to mute themselves. So, yes, I see. Have you ever had to repeat multiple times the same information about your health, your blood work, and family history to different providers? I see a lot of yeses popping up. Okay. Have you ever had to take your lab results or your medical records to another provider instead of them ensuring the information was sent and received? Yes. Have you ever had to refer your family to another medical specialty or social services, but you didn't really know who to refer to in your community? Or let's say you wanted to refer an immigrant family to a provider that speaks the same language as the family, but you had no idea how to find this professional. Yes. I see a lot of yes. Okay, one no, good. All right, thank you. Thank you so much for participating. If you answered yes to some of these questions, as I see, you probably experienced some type of continuity of care gap from either a patient or a provider perspective. So continuity of care is how one patient experiences care over time as coherent and linked, but this is an outcome of good information flow and intentional coordination among providers in the back end. So continuity of care in chest breastfeeding is achieved by collaborative and seamless delivery of high quality services. Continuity of care results in transitions of care that are coordinated and fully supportive of families throughout their chest breastfeeding journey and during the first 1,000 days. So here you see part of the blueprint. It's part of our blueprint infographic. In our last webinar, we talked about the outer circle, the importance of having supportive environments throughout the community. Today, we'll focus on transitions of care. So let's take a look at the light shaded area in the middle. Each row represents one of the dimensions of continuity of care. So this top row here represents the management continuity, and it relates to communication and coordination among providers. The middle row is the informational continuity and illustrates medical records of both birthing parent and their babies traveling together and being shared from one provider to another. This third row here represents the relational continuity, which is the relationship aspect between family and provider. So in this second image here, you see the extended circle of care model that we adapted to lactation support. So this image also illustrates the 3 continuity of care dimensions. So again, in the blue zone here, you see management continuity that emphasizes the importance of interprofessional communication, especially when a patient is cared by many providers in different settings. On the bottom of the image, you see in purple, you see the informational continuity that refers to the connectedness and coherence of how relevant information from prior events travels through the health system and is available over time to help inform current care. But in reality, we know that lactation support providers in the community rarely have access to hospital charts and feeding history that is important, right? So today we address the management and informational continuity, so the blue and purple pieces, and Linda's gonna talk a lot about the informational piece especially. And the green part representing the relational continuity will be part of our next webinars. So we're not gonna talk too much about this today. And all these little petals, I don't know what those are, but I mean, it looks like a flower. So these little petals all around this became strategies for the blueprint to establish continuity of care. So here, finally, is the blueprint recommendation number 3, which is the topic of today's webinar. In the blueprint, you find a list of useful tools, success stories of implementation, and resources related to this recommendation. So recommendation 3 states to implement a care coordination system across the prenatal through weaning stages, including the development of referral systems, follow-up accountability, and handoff protocols during transitions of care from one provider or setting to another. So this recommendation was set to ensure that families do not fall through the cracks during those transitions of care. But we know that problematic transfer of care occurs in all types of healthcare settings. And within chest breastfeeding, the first 1,000 days, a family unit transitions across multiple providers and settings. So continuity is achieved when all providers deliver consistent care that is responsive to the family's changing needs. So when there's a lack of continuity, parents are less likely to initiate chest breastfeeding, or they're unable to breastfeed exclusively or for the recommended duration. So to address all these continuity of care breakdowns, these are the 8 strategies under recommendation 3. So first here, 3.1 is to improve consistency of chest breastfeeding messaging by co-creating training, educational materials with other stakeholders in the community. And this is so important because parents often complain about receiving conflicting messages from different providers. And this may cause confusion and can ultimately result in unintended weaning. 3.2 here is to develop and continuously update a lactation support resource guide, including a culturally inclusive compilation of services available in the community. So this community director should be easily accessible and given to all organizations serving pregnant and postpartum parents. So 3.3 talks about establishing community clinic linkages among healthcare and community-based organizations and other lactation support providers. So this relationship can lead to a memorandum of understanding, a MOU, or other informal agreements to ensure seamless transitions of care. A classic example for these community clinic linkages is communities supporting hospitals to strengthen baby-friendly hospital steps 3 and 10. Those are steps related to prenatal and postpartum support. So those agreements help establish care continuity and care accountability. And then 3.4 relates to developing systems that allow safe sharing of information across institutions such as WIC, public health programs, individual providers, and healthcare systems. And then 3.5 relates to developing workflows with bidirectional referral system that emphasizes handoff, accountability protocols to ensure the transfer of care responsibility and transfer of critical important information, such as potential risks for lactation discontinuation for a family. So these 2 strategies, 3.4 and 3.5 that I just described, speaks to the investments that are needed to strengthen the infrastructure for patient information systems. Things like interoperable electronic health records, enabling health information to securely follow the patient when and where it's needed across providers within the continuum, and possibly generating automated e-referrals with proper exchange of information. This is so needed because systems that allow for proper referral with timely handoffs help reduce the burden on families of having to seek help and repeat relevant personal information multiple times across all providers. So 3.6, strategy 3.6 talks about designating a lactation care coordination role to assist families in navigating and accessing appropriate services in a timely manner. This coordinator should ensure that follow established and received. So lactation referrals are fairly common, right? But it's less common for an entity to ensure that the lactation follow-up care is culturally congruent, that are scheduled and are indeed received, and that the care is coordinated across settings. And of course, in many communities, there's limited support available, which makes referrals even more difficult. And further complicating families and provider navigating the services in the community is the confusion regarding the different types of trained individuals providing lactation care in communities. And then 3.8 talks about establishing a screening tool or triage system for lactation-related concerns that includes timely referral to the appropriate level of care. And then the 3.7 speaks of identifying potential pathways to increase reimbursement for all types of lactation support providers to ensure there's available paid professionals to refer to in the community. So many of the strategies revolve around this concept of a handoff. And that is because one very common breakdown in continuity of care in any healthcare field is during the communication or the lack of communication during transitions of care. One simple tactic to reduce errors in communication there is to adopt protocols for proper handoff. So let's talk about warm handoff here for a minute. I've seen many different definitions and understanding of what a warm handoff is. So let's just take a poll to see what you understand of warm handoff. So we're going to do a poll, and I wanted you to let me know what you understand a warm handoff is. Do you think it's a mechanism for transferring information, or it's a document signed by the postpartum family authorizing to be contacted? A warm handoff is conducted in front of the patient, or it's a handshake between care providers when their hands are warm. I don't know if I could do a warm handshake right now because my hands are cold. So we're gonna give you like 10 more seconds to vote. All right, so that's great. Majority of you selected the correct definition according to the authorities in this topic. So we use the definition from the reference authorities, like I said, that is the Joint Commission and the Agency for Healthcare Research and Quality. So they have so many resources for warm handoff protocols, and they are all referenced in the blueprint. So handoff is the transfer of information along with transfer of responsibility during transitions of care. So intentionally clarifying the sending and the receiving roles plays a critical role in decreasing gaps in care. Handoffs can occur between any two members of a healthcare team, including like clinicians, medical assistants, front and back office staff, and outside members of the extended care team. Now, the term warm handoff, it goes beyond the regular handoffs and at another extra level or layer of safety by engaging the patient and the family as key part of the care team. So ideally, a warm handoff means that one member of the care team introduces another provider to the patient, explaining why the next provider in care can better address a specific issue with the patient. So warm handoffs improve patient safety by helping prevent communication breakdowns, because it allows the family to verify the information being shared about them, ask clarifying questions, and provide inputs in their care plans. So the reality really is that most workflows in clinical settings don't really support the use of warm handoffs. And within lactation support, in-person warm handoffs gets complicated because of the many different settings that families transition through. However, involving families could also happen remotely, like with telehealth or via phone calls or texting and email. But in any case, either handoff or warm handoff protocols needs to be intentionally planned and implemented. Otherwise, it will not automatically happen properly. So finally here, I just wanted to close this background session and show you some examples of what NACCHO's current and past grantees have worked on related to this recommendation. And I'm gonna share very briefly more than 10 community examples. So it's gonna be just quick highlights, but if you'd like to learn more about specific one that I mentioned here, please contact us. We'll be sure to give you the full context or connect you to the right person, right? So like I said, currently we have 10 grantees implementing 2 or more blueprint recommendations. And on this slide, you see 5 of these grantees working on recommendation 3. Then you're gonna hear from Cincinnati that is also doing a lot of strategies on the recommendation 3. But first here we have University of Chicago Medical Center. They have been piloting a peer counselor position within their health system because of the many continuity gaps they experience, given the unique nature of being an university hospital. So pregnant and postpartum families rarely see same providers consistently because clinics are staffed by residents, students, and supervised by a rotating roster of attending physicians. Also, they have a heavy caseload of high-risk patients transferred to the high-risk clinic late in the pregnancy from outside organizations. So at no surprise, they have identified many, many barriers to lactation success in this clinic population. So the peer counselor that they're piloting, and note, it's not like a weak peer counselor, it's their peer counselor. Usually we see weak peer counselors co-located in the hospital setting, but this is different. So the peer counselor is providing education and support during the second and third trimester and in the first few weeks postpartum. So they're working on their EHR system for touch points for lactation support entries and electronic handoff referral protocols. So the peer counselor can chart and make referrals easily. They're also working to provide families with a paper like a lactation after visit summary, so families don't have to keep repeating their information over and over when they transition to providers. And another cool, interesting community clinic linkage tool they developed is a returning to work package that includes a physician letter to employer on the University of Chicago medical letterhead, explaining what the lactating employee needs from the employer. So you kind of see a screenshot of the letter there, but the letter template is available on your Blueprint website. Then next, we have the Black Mothers Breastfeeding Association in Detroit that is partnering with Focus Hope, which is their early care and education provider, and their WIC program. So they're working together with the WIC community liaison and the Focus Hope lead home visitors on a referral flow chart for a proper handoff procedure. And then next, in green box there, you see Thames Valley Council for Community Action, which is an organization that addresses different social needs for the families. They're training different types of staff like their home visiting, their finance literacy instructor, their fatherhood program coordinator. So no matter which door clients enter through into their agency, they get the same consistent breastfeeding education, and when needed, they're properly referred to their IBCLC. So they're working on consistent messaging guide internally and also doing outreach to community OB providers to get them on board too with this consistent messaging and referrals. And the next two grantees you see here in red and blue, they did not explicitly select to implement recommendation 3, but we clearly identified some of the strategies in their work. So on the red box is the Asian South Asian Pacific Island Breastfeeding Task Force, who partnered with Breastfeed LA and the Asian Health Centers. So they had conducted the providers' needs assessment within the clinic and identified several opportunities to improve continuity of care. And then with that, they're working on culturally responsive prenatal breastfeeding toolkit and also working to update their electronic health records to improve information exchange among their perinatal health workers and pediatric staff. So another great accomplishment is that they have linked both parent and baby's chart. So both charts now have lactation support appointment notes available. And finally, Florida Keys, they connected clients to services all the time. So they're training partners and their staff as CLC. This way, when a staff member goes to a family home to install a car seat or deliver diapers, they will be equipped to provide face-to-face support and connect them to more advanced lactation support when needed. So you can see these Blueprint grantees are very busy. They're set to complete this grant within the next couple months, and we hope to share more of their results in our next webinar. Here, a quick shout out to all REACH recipients doing wonderful continuity of care work in their communities. We're happy to see so many of you here today. Some of the REACH recipients have been doing innovative work in this area, and they're effectively taking the burden from families to have to seek lactation support. REACH San Diego established a clinical process to have free breast pumps delivered to families. This was super helpful during the pandemic. They delivered over 380 breast pumps. REACH Michigan worked in a GIS, the system, to develop an online mapping to make lactation support locations easier to find. And then REACH Pima County partnered with our former grantee El Rio, did a MASAT mapping and developed a warm line in English and Spanish, which was also very, very helpful during the pandemic. And REACH Nevada partnered with State Coalition, Home Visiting, and other cultural partners to increase consistent messaging among all partners and over 60 newly trained CLCs in the community. So we're very, very proud of all the work being done in REACH communities. And finally, those resources here from years ago, but it's still super relevant. Here at NACCHO, we've been talking about continuity of care for so many years, even before envisioning the blueprint. So in 2016, we hosted the Closing the Care Gap webinar, and then 2 of our former grantees presented. You can see a screenshot of their work. There's an electronic care flow protocol with so many touch points for lactation support, and then the care responsibility assigned to different staff members. And then Contra Costa did culturally responsible referral systems from hospital to community for Black families delivering their hospitals. And they do so much in navigating like both hospital and community electronic records. And then in 2019, we further explained the continuity of care concept by borrowing the community clinic linkages concept. And then we had speakers from Lactation Care Center in Texas and Mississippi Department of Health, sharing how they establish referral systems processes with surrounding hospitals, delivering hospitals in their community. And Monroe County is one grantee that we keep highlighting because they've done such seamless warm handoffs because they co-located lactation support providers into OB and pediatric clinics. So if you're interested in this particular topic of the blueprint, I highly recommend that you go back and watch these webinars. And then we add a lot more resources to recommendation 3 in our blueprint website. So you can see there, you can go to the breastfeedingcontinuityofcare.org and find resources to help establish this care continuity. There's a sample agreements and a training module on automatic referral systems, and then an online resource guide. So now I would like to turn it over to our first speaker, Linda from MAMI. We're lucky to have access to their expertise as one of our consultants for the Blueprint grantees. And Linda is co-presenting with Dawana, who is also here in Washington, D.C. She works as a care coordinator and assists the district expectant and new parents navigating the health system. So Linda, I'll turn it over to you.
Thank you so much. It is such a pleasure to be here. And listening to all this I'm just so excited. My name is Linda Hanna. I'm the Chief Nursing Officer and one of the co-founders of MAMI. I co-founded MAMI with my daughter, Melissa. She's pictured with me on this slide. I'm in pink. MAMI is a healthcare delivery platform for maternal and infant healthcare. I'm thrilled to be here to discuss what I have built my life's work around. We're going to talk a little bit about MAMI's core tenet, making it easier for providers to coordinate care. When we do this, we ensure birthing people and their families have all of the support they need. Later in the presentation, you'll hear from one of our partners, Help Me Grow, about the work we've done together. Let me first, before we move forward, discuss just a conflict of interest. As I mentioned, I'm on the leadership team of a for-profit company called MAMI, and I'll be discussing some of the work we've done with the company. This webinar was not designed to sell anyone on a virtual platform. What we've done is gathered leading research on the work that we've done in care coordination work. I hope you can take the lessons that you learned today and incorporate them into your practice, no matter which platform you use to coordinate care. Let's talk a little bit about the accountability. And it's so interesting listening to Harumi talk, and all of the things that we hold so near and dear to us. Patients tell their stories over and over again, and they oftentimes forget something with one provider and share that with another provider, and people don't always know. There's a miscommunication sometimes between the family and the care providers and all of the clinicians caring for them. And not everything is always linked up the way it should be. So let's talk a little bit about why this is so important. And how did we get here? Switch slides. So this is one of the most important things we have to talk about. It's communications. So let's go forward and another slide, thank you. And talk about how we got here. Part of this is from technology. As you just heard, that the hospitals and the health systems and even the allied health professionals all use an EHR that's basically siloed. It's not shared, for example, amongst all of the different providers. It's siloed in the hospital walls. Allied health professionals, that's all of us. We all have our own tools that we use. And those tools are often separated from the EHR so that there's not a lot of crossover, for example, between the providers and the people who are caring for the families and what the families actually need. So it's actually the opposite of coordination of care. So let's talk for a minute here, just ask a couple of quick questions for yourselves. How easy is it for you to, before we do our poll, This is going to come up in a second. How easy is it for you to find other organizations and other providers to work with? How do the families actually get access to them? And then, do you know that the families have other providers that they're working with and the work that's being done for them? So let's just talk a little bit about the poll. Let's just ask a quick question. What resources would be most helpful to get started with care coordination systems and referrals? Here's your little poll. Let's see what you all think, knowing which more, if there are more organizations in your area, having a care coordination workflow, understanding the patient's referral needs, buy-in from other colleagues across different organizations, or knowing that you can safely share patient health information across the care team. Let's see what everybody says. I'll give you guys 30 seconds, and we'll see what the results say. Having a workflow, that's very important too. And safely sharing HIPAA protected information. Those are the two heavy hitters. They're all really important, but we see that a lot of people want to make sure that they can share information safely. We'll talk about that today. Let's first go and talk a little bit about one of our core tenets. It's communication. It's essential. Having a communication tool should happen in the same place so that everyone knows exactly what the needs of that diet are. You heard just earlier how important it is to initiate warm handoffs and warm referrals, using shared decision-making for the patients and the providers. The parents and families deserve to know that everyone is sharing amongst themselves and each other the information that's vital and essential to that family. Ask yourselves a couple of quick questions now. What's the best way for you to communicate with families? I know some people are texting and some we just heard about messaging. We'll talk about that as well and how our platform works. How do you communicate with other care professionals who are caring for the same family that you are? And do you feel ever that you wish that you had the documentation in front of you, or that you had a list of the resources that that family was given to, and how could you find that information? We're going to talk about that as well. You see the staff here communicating over a platform. Let's go on and look at what goes on in the circle, if you will, of communication. We have our beautiful mother in the middle with her baby and all of the people around taking care of her and her family. So what you can see here is a lactation consultant, maybe her midwife, other healthcare practitioners, people who are helping provide extra support for her in the community, for example, at the food bank or at some of the other organizations that family might be referred to, someone from the DC WIC Foundation, for example. All of these people are circling around the family to make sure that they are getting all of the support and attention that they need. Next. So let's look a little bit about what has happened in research. We know that a lot of things happen during the patient's experience from prenatal to postpartum, and you heard about the first 1,000 days. If we can increase the parents' ability to get to their appointments, whether that means vouchers for traveling or making sure their appointments are timely, depending on their own work schedule or home schedule, or other family members at home that they need to take care of. If we could just increase attention to prenatal appointments, the physicians and midwives and healthcare providers could potentially help us with reduction in blood pressure issues, hypertension, prenatally and postpartum. We could send families to classes to help support some of their own behavioral health issues, for example, smoking cessation programs. Decreasing tobacco use is very important. It's possible with prenatal care and attention and support, preterm birth can be reduced. We know that the March of Dimes is working very, very heavily on these particulars, very important issues, and low birth weight. And we know that prenatal care, prenatal attention, prenatal support, and all of the networking of the people who support that family help reduce these unnecessary risks and help reduce the number of babies who are admitted to a NICCU. That's a very financially prohibitive. And we want to make sure that we help these communities. So we're going to talk a little bit about how we address continuity of care. First of all, it's whole person care. That means we're addressing mental health issues, psychosocial, social and emotional health and wellness. Timely and cultural appropriate referrals allows for our marginalized communities to connect with culturally congruent care and lead to continuous and comprehensive support. You heard that in the beginning of this presentation. That was everything that all of these community resources are doing. They're just not connected. They don't always hear each other and talk to each other. The key component to reducing racial disparities in healthcare is putting everyone together, linking all of these services and all of these support mechanisms together. It's extremely important for our communities that are facing racist systems. We can help fix this. We can put all of this together. Again, whole person care, timely and culturally appropriate referrals, and continuous and comprehensive support. That's what our intention is, and that's what we would like to do. But we also have to realize that we have to work together. Let's talk a little bit about modifiable health components. This slide, which is a little bit older research, shows where the breakdowns are for our families. Back in 2010, research showed that 20% of the modifiable variations in health outcomes was due to clinical care. 40% was due to social and economic determinant factors, and 10% to the environment. 30% was due to behavioral health behaviors. It's an urgent reminder that we must be recommending that we refer to one another. We're only one piece of a puzzle. We need to transfer care when appropriate and make sure that our patients, all of our patients, and all of the families are getting the appropriate referrals and support they need. We want to thank and show gratitude, next slide please, for the friends and family partnerships that we've worked with and that have used the Mommy platform. Here's a list of some of them. You can see we have working closely with Uzazi Village, Her Health First, Perinatal Health Equity Foundation, Navajo Breastfeeding Coalition, and many, many others, Accompany Doula. These all are leaders in health equity, and we're grateful to have them as partners in developing and improving solutions for care continuity and care coordination. They're part of the many regions that have implemented and used Mommy. We include Ohio, Missouri, Pennsylvania, and Massachusetts, just to name a few. Now we're going to show you how we worked with the teams in Washington, D.C., a specific example of continuity of care and bidirectional referrals and what it looks like when it's put into action in the District of Columbia. So just for our goals with Mommy and DC Health, increase collaboration of care between providers, connect patients to their whole person care, as I mentioned multiple times now, and also Hiromi also mentioned as well, standardize the comprehensive care model, and reduce maternal mortality. Three things that make this work are these: software, community, and nurse-led care coordination. But let me be clear that the amazing work done in DC by people on the ground makes a real impact on maternal health. There are people and organizations, you'll see them soon, who already have the solutions to solve the problems. What Mommy platform did was add the digital infrastructure to connect all of the DC birth centers, hospitals, allied health professionals, and all the other ancillary people to secure them in one ecosystem so everyone could communicate and collaborate on care. Our job was to be in the background with a nurse-led team to help make sure that everyone was connected, the providers and the families, so that we could escalate care as needed. All in all, our project was software, community, and nurse-led coordination. Look who we partnered with. Go ahead. There you go. 100 organizations, over 1,400 providers, and over 27,000 mothers and families through the birth centers, coordinating care amongst the community, health systems, clinics, medical offices, our lactation consultant, and all of the doulas who do the amazing work they do to make sure that the families are getting the care they need. Look at the list. There's just a few. Unity Health Center, MedStar Hospital, Birth and Milk Company, the Breastfeeding Center of Greater Washington, Mamatrice, just to name a few, all use the platform and all help us organize and coordinate the care. Next, let's explain a little bit about how it works. We do social needs screening. There's your blueprint, strategies 3.8 and 3.2. The parents would actually sign up for Mommy, either through their physician providers or through an advertisement. Every time someone signed up from DC, they would automatically be given a social needs screening. The patients would be asked about needs regarding transportation, healthy food, safe housing, and insurance. And based on those needs, relevant resources and direct contact to that referral, including enrollment instructions, is automatically assigned to the patient's care plan. It's critical because in order for us to facilitate these referrals, we need to identify what the patient's needs are. Aligning again with 3.8 and 3.2, patients could also look at a resource directory with providers, lactation resources, and other important providers near them, which supports again 3.2. We also have, next slide please, our VRN, our virtual registered nurse. Once they fill out their screening, our care coordination team is automatically flagged with the services that this person is seeking. Once the referral is made, the message is sent to the patient and to the appropriate resource to help facilitate that they get the care that they need. When the patient responds and replies to the care coordinator, any additional information regarding any support concerns are documented and then given to the appropriate resource or provider. Every interaction is noted on the platform. There's space for every provider to document what has happened so that everyone can read each other's information and not have to miss things and lose information on the transfer of information. Here's how it works. Our patient fills out, go back one slide for a second. So facilitating a warm handoff, as we just mentioned before, is very, very important. It's probably the essential piece, whether it's through the system or individually or virtually with our patients. Next slide, thank you. So the patient completes her social needing, for example, needs screening, for example, and she says she needs some help with affordable food. The care coordination team is alerted and then submits a referral to DC WIC. DC WIC staff complete the referral and find out the eligibility, screen the patient, and enroll them. All of the communication with the patient, the mommy care coordinators, and the resources are documented and housed inside the mommy platform. Then mommy sends the social needs data into the Regional Health Information Exchange known as DC CRISP. So all of the information is contained and housed and is constantly flowing back and forth between the providers, the patient, and the referral. Next, in addition, the nurses, myself included, for example, are constantly in coordination and checking in on the patient all the time. Once they've filled this out, the next slide, please. Once they fill this out, our virtual nurses pop in, myself and my team. We would message the mom in the platform, provide personalized and proactive and preventative health information to allow for early intervention before crisis. We flag and escalate. That's really important. The providers need to know what's happening with the families. We identify blood pressure concerns and other medical issues that might be happening to this particular family during prenatal and through their intrapartum as well as their postpartum experience. We give allied health professionals, along with 3.4 in the blueprint strategies, opportunity to share information across the network, serving in that DC area with charting tools at no cost to any of the providers, and with the patient's information available. We ask them permission to share across our HIPAA protected secure platform. That was the #1 on the poll, to make referrals inside and messaging inside our secure platform. In addition, they could also flag and additionally offer support to families when needed with recommendation 3.4. So we're trying to house all of this inside the platform so that all of the allied health professionals have a safe place to work and to do their best work for families across our counties. Let me introduce you to Dewana Brown from Help Me Grow, and she'll share with you what they've done using the Mommy platform. Thank you for letting me be here. It was a pleasure. I'm so thrilled for all the work that's being done. Thank you.
Thank you again, Linda. Good afternoon, everyone. My name is Dewana Brown. I am a care coordinator with the Help Me Grow DC team. Help Me Grow is a nationally affiliated program which began in Connecticut. So let's give you a brief overview of what Help Me Grow DC does. The goal of Help Me Grow District of Columbia, or we like to call it HMG DC, is to support healthy births for pregnant mothers and promote healthy development for children ages 0 to 5 in the District of Columbia. Help Me Grow DC is a unique, comprehensive, and integrated district-wide system designed to address the need for perinatal supports, early identification of developmental and/or behavioral concerns. Families are paired with a Help Me Grow care coordinator, such as myself, to assist with navigating district-wide resources and services. Help Me Grow partners up with Mommy. Let's talk about this teamwork very quickly. Help Me Grow care coordinators are designed to perinatal or postnatal moms who utilize Mommy platform to seek help services such as breastfeeding support, WIC enrollment, safe sleep, housing, and other sources are available. Mommy works closely with HMG care coordinators to ensure requested services are, of course, completed and gaps of care are closed due to the intake and follow-up processes conducted by Help Me Grow care coordinators. So really quickly, to make sure that all of the continuity of care and care coordination is a wraparound service, all expectant mothers have access to wraparound services to promote healthy birth outcomes. And some of these services are breastfeeding support, infant safe sleep with cribette distribution, infant seats and child booster seats, WIC enrollment, insurance benefit enrollment, TANF and SNAP enrollment, and also housing placement application preparations. So Help Me Grow kind of keeps it going together with the support of the Mommy team as well. Thank you. And right here, you just have a brief dashboard of our residents who are served in the District of Columbia. You have DC residents who signed up for Mommy, running in at a total of 368. You have about 59% of our moms who utilize Mommy who require assistance with social needs such as food, housing, transportation, and also patients who created a perinatal and postpartum birth plan is coming in about around 63%.
Here are the lessons learned. I hope everyone can hear me now. Automating delivery of commonly used screening tools allows us access to lactation consultants and the care that the moms need much faster. This is essential. We've talked, how much have you heard about breastfeeding, how important it is, especially now, our country's in a little bit of a crisis. Thank God for our breastfeeding mothers and the milk sharing. Safe sharing of breastfeeding and health-related patient health information across health systems and institutions is critical. We know that. We're all doing this. Everyone on this call is doing this. Making sure that bidirectional referral communication systems that promote warm handoffs is essential in the transfer of care. We know that. We've spent years researching this. This team that's done the work today, Help Me Grow, and all of these organizations, we're all doing very similar things. We just all want to be connected to one another. So this is what we learned, and building the platform helped us do this. Thank you so much. We're so happy we could be here with you.
Thank you, Linda and Dawana. That was a very great, very informative presentation. Thank you so much. Now I would like to turn it over to our superstars that are currently implementing some of the blueprint recommendations in Cincinnati. The work is still unfolding because we're in the middle of the grant period, but we think that sharing the process is just as important as sharing the final results. And they also represent one of the best community clinical lactation partnerships we have seen in this past year. So welcome, Dr. Ware and Jamaica. And please continue sending questions in the Q&A that we're going to address in the end.
Thanks, Harumi. We're so delighted to be here with you today to talk about Cincinnati's multidisciplinary approach to breast and chest feeding continuity of care. I'm Julie Ware, and I'm from Cincinnati Children's, and here with my colleague.
I'm Jamaica, Gilliam, or Jamaica like the country is what everyone calls me. Great to be here.
And I'm just a little bit in awe of our last presentation and Harumi's introduction. And I do feel like we are kind of doing baby steps toward this continuity of care, but really we're so excited to share with you where we are in our process. So we're doing this with partners to make inroads towards improved continuity of care. I mentioned that I'm from Cincinnati Children's. We have Hamilton County Public Health Department's Ohio Equity Institute team, which you'll hear more about from Jamaica, our Southwest Ohio Breastfeeding Coalition. All of our area birth hospitals are working together on this. Of course, WIC and our Amen All Moms Empowered to Nurse Breastfeeding Peer Support Group. Next slide. So this is busy, and I don't intend for anybody to try to even read these little circles and trapezoids, but this is just to show you that Cincinnati Children's Center for Breastfeeding Medicine has a lot of folks working on breastfeeding, both inpatient, outpatient, in the NICUs, at the various birth hospitals, in research, and those green boxes are actually community members. And I just wanted to say that after working initially on this continuity of care project, we're going to have a whole entire page for our wonderful community partners. Next slide. So I am taking sort of the clinical approach to what we're working on, and our Cincinnati hospitals are working very hard. I've highlighted 3 of my colleagues here who work in the various birth hospitals. Cincinnati's a little unusual. I think that all of our area birth hospitals, except 2, are manned by our newborn care associates who work at Cincinnati Children's. So although there are different hospital systems, we can introduce some similar methodology in the various hospitals across systems because of this newborn care associates staffing. We have some hospitals who are baby friendly, some hospitals who are working on the Ohio First Steps designation program, which is all about introducing those 10 steps to successful breastfeeding. Sorry, next slide. But what happens after we do such a great job in the hospital? What happens after discharge? Next slide. So you all are probably well aware of this graph from the CDC National Immunization Survey from our most recent cohort 2018, that once moms start breastfeeding, and thankfully 84% of them do start breastfeeding, and a little over 60% with exclusive breastfeeding, there's a rapid drop off over time in continuation of breastfeeding. Next slide. This also continues locally in Cincinnati, and there's been a recent cohort of babies followed in Cincinnati, and the continuation of breastfeeding is noted here. If you look at the left panel, that is our Black infants in the cohort. There were 92, and on the right panel, 113 white infants. And you see the blue bar is exclusive formula feeding. So you see over time at week 2, week 6, 4 months, and 6 months, we have increased formula feeding, as we have seen in the CDC data, but we do have this disparity between our Black and white infants in our community. Next slide. So because Cincinnati Children's has the newborn care associates in the hospitals, we also were able to look at, of those babies who come to our 3 primary care clinics, how many of those babies who initiated breastfeeding at the birth hospital are still receiving breastfeeding at that first visit. So we found, when we looked at our data, 10 to 20% of babies were no longer receiving any breast milk at that first visit. So we created a quality improvement project to increase that number by at least 5% over the next 12 months. Next slide. These are some of our teammates. We increased it from our neonatologists to our primary care lactation staff, some of our prenatal hospital Lactation, our residents, our WIC directors, and community members to work on this project. Next slide. And this is for any of you involved in quality improvement. This is from the Institute for Healthcare Improvement, the key driver diagram, where you kind of, as a team, as your multidisciplinary team, try to think about what is driving the outcome that you're seeing that you want to work on. So we've talked about our aim, but in that middle column, you can see the key drivers that we think are affecting this problem, this 10 to 20% discontinuation. So we felt like consistent breastfeeding education was important, that community partner support of breastfeeding, which is what we've been talking about today, mother's perception of her milk supply, are we even measuring the right things when we're collecting this data, and knowledge of the stressors mothers are facing, is the infant learning how to latch, and then this flashing light at the bottom box, timely newborn visit from hospital discharge, right? And on the right side, some of the interventions we've been working on include prenatal breastfeeding messaging and the warm handoff. Next slide. So don't worry, this slide is very busy, but just to give you an idea, we have been working on this for a while, since 2018. On the x-axis are the months and how many babies came to our 3 clinics. On the left, the y-axis is our percent still breastfeeding at the first visit. That solid red line at the top is the mean. So you can see even despite all of our efforts, we haven't moved the mean from about 88% still breastfeeding at the first visit. All the little yellow boxes are different interventions that we've had in this project. You can see our blue boxes for our friend COVID popping in there with Delta and now Omicron, and even our little icon of the vaccine, which was mandated and affected some staffing at some of our hospitals. But I want to point out the red box, the sound the alarm for newborn access, because that is something that our team really was able to do as a multidisciplinary cross systems team when our newborns were not getting in a timely fashion in the beginning of COVID. Next slide. So when moms are no longer breastfeeding at the first visit, we try to call them and interview them about what are their reasons for discontinuation. And the top reason is not enough milk or perceived not enough milk, followed by difficult latch or hurting with latch, and so on. Next slide. So some of those reasons then informed our education that we worked on in the project so that moms could know, is my baby getting enough milk? This is just one example created by one of our hospital systems to share with families to let them know what is the baby's tummy size on day 1? How many wet and dirty diapers can you expect? And then our favorite Dr. Morton droplets videos were made into QR codes for families to go get more video help on some of these questions. Next slide. So as I mentioned, we learned that 10 to 20% are no longer receiving breast milk, that we weren't always getting them in a timely fashion. And then we didn't have a systematic way of letting our outside providers know of red flags of possible breastfeeding difficulties. Next slide. So we knew for digging down, diving deep, as they say, into this warm handoff piece, we needed to add even more team members. So we're delighted to have Chris Auer, one of our lactation consultants in the area, some others from some of the major birth hospitals that do refer to our primary care clinics, our WIC breastfeeding coordinator, and nurse manager from one of our big hospitals. Next slide. And then we used the evidence. We went to the evidence and tried to find out what are those risk factors we should be highlighting when we're making that warm handoff referral. So we went to the Evidence-based updates on the first week of exclusive breastfeeding by Dr. Lori Feldman-Winter and colleagues. And I think the next slide's going to be our little case study and poll. This is actually a real case. Name has been changed, of course. This is for you to kind of think about the risk factors and when you would have a follow-up. So this 36-year-old gravida one conceived by IVF. She had a history of insulin-controlled gestational diabetes, hypothyroidism, anxiety, and depression. She was induced at 37 weeks for these pre-existing conditions. She had an intrapartum hemorrhage, but no transfusion. The baby went skin to skin, but only was able to latch with a nipple shield and went home at 48 hours. So what I'd like you to fill out on your poll is, when should this baby have his first newborn check? Okay, we have, I guess our number one answer was 48 hours and followed by next day. Okay, I hope, Erica, you can hold that for me. And when we get to questions, if people want to go into more detail about what happened to this real case baby, we can go into that. So next slide, we again went to the data and we collected our favorite risk factors for our multidisciplinary team, looking at maternal history, what happened in the delivery, postpartum issues, and then infant issues. And you could remember baby boy Smith and mom had quite a few risk factors. So one of our hospitals already has a very nice lactation note that includes many of the risk factors noted here. And so next slide, what we are hoping to do is to incorporate those risk factors into the flow chart in EPIC, which is the system we use for our EHR, and then develop a dot phrase that will pull these risk factors into the discharge note as a mandatory field for the discharging provider. So in other words, the lactation consultant notes XYZ risk factors, and as the discharging provider is getting ready to discharge the baby, that field must be completed and it's automatically pulled in so that the discharging provider knows this baby has a lot of risk factors. I need to have this baby seen tomorrow instead of 2 days, or whatever the case may be. And then we are also in the process now of identifying our hospital and other outpatient options for babies to come back. For instance, if the pediatrician cannot see the baby the following day, but the baby must be seen for various reasons, what are the options? How can we get the baby in? So that survey is in the field, as well as a pediatrician survey that we're going to share also with family practitioners about what lactation care they can give in their office and how they would like to receive the warm handoff that we're going to give them. So yes, this is, I've just told you a little teeny tiny piece of the clinical part of the work. We are all going in the same direction in the river. This is not the Ohio River where we live. And I'm really excited that now you get to hear from Jamaica about the community part of the warm handoff. Take it away.
Hello, everyone. Thank you so much, Dr. Julie, for explaining all of that about our clinical side. So I think that we have talked about clinical and community and how they mesh. And I really want everyone to understand that the community is a part of the care team, right? So when moms are discharged, they are handed off into the community, but we don't really talk about that part. So again, my name is Jamaica, and I am an Ohio Equity Institute navigator. So if you're familiar with like a community health worker, I'm a little less invasive, but a little bit more creative. So what we do here on our team is we work to achieve equity in our local communities by ensuring Black pregnant and postpartum women have access to services that will support healthy pregnancies by improving their physical and social infrastructure that impact health outcomes for Black women, children, and families. So basically, we connect women to resources in a creative way through non-traditional means. We do not get the majority of our moms that come through our program from clinics or other social determinants of health resources. We find these women in places that are non-traditional. So laundromats and bars and different places that you wouldn't necessarily think moms and babies are going to be in. Next slide. So again, remember, the community is a part of our care team, is part of Mom's care team. And with that is the attitude in that community. So that's where the BACS project came from, which stands for Breastfeeding and Chest Feeding Community Support. Next slide. So our BACS team, folks, we have myself and another project coordinator, and we also have 3 community breastfeeding advisors. And as a team, we've done a lot of boots on the ground. So we have gone door to door, we've done cold calling, we have pushed out surveys into our community to understand what is the attitude in the community, what is the narrative that's being spread, especially in these spaces. So next slide. So we want folks to breastfeed anywhere, everywhere. So our mission here at the BACS Project is to identify, support, and acknowledge local breastfeeding friendly spaces and organizations. Again, they are pillars in the community. So we want those spaces and organizations to have a breastfeeding friendly attitude in their businesses, workplaces, and especially childcares. Next slide, please. So a part of our BACS project is something we have called the Pushbacks list. So that stands for People United in Sharing Helpful Breastfeeding and Chest Feeding Community Support. So this is basically our one-click list that all of our providers will have, all of our community resources folks will have also. So we will have all sorts, we will have one point person from each one of these community organizations, and they range from coffee shops, play places, to folks like, I know Help Me Grow, we had heard from them. Our local Help Me Grow representative is also on this one-click list. And so we have a point person, they go on a list, and any sort of breastfeeding events or information that we want to get out into the community, into moms and babies' hands, this is how we do that very easily. Next slide, please. So with the Southwest Ohio Breastfeeding Coalition, we have always had a resource list and a website. But with this particular grant cycle, we have really gone through this with a fine-tooth comb to see how is this serving our community. So updating everything, everything from local breastfeeding laws, where to get pumps, what different hospitals are doing. So this is, it has its own website. And of course, all of the resources and our partners have access to this also. Next slide. And again, we went through this with a fine-tooth comb and trying to figure out the best way that this resource list is going to serve our community. And we saw that there was definitely a need for maternal mental health resources. So we have collected all of those things and put them on this resource list also. Next slide. One great update that I think that we have done is added a calendar to our website. So our resource list has a website. And so any sort of meetings, support meetings, so our All Moms Empowers to Nurse virtual meeting, which is held every Friday, is on here, and it will link to our AMEN website, and also our Southwest Ohio Breastfeeding Coalition monthly meetings. things like the Big Latch, our Black Family Reunion, anywhere that is going to have breastfeeding specific information, so classes and groups, we will go on to our calendar. Next slide. Another really great resource that we have is our Ohio statewide breastfeeding hotline. It is a 24/7, 365 days. No matter what time it is, you can call and be able to talk with someone. And it is in English and Spanish. Next slide, please. So again, we have remembered that the community is a resource. It is a part of their care team. So we have wanted to build the Lactation Community Task Force. So we have had some really great mentorship from an IBCLC, Chris Auer, and she is mentoring 3 women of color that is going to be doing their CLC exam. We are also going to be holding a breast friend training, and that's a Rose training for at least 10 women of color, really to help meet up our breastfeeding task force in the community. Next slide. Thank you all so much for listening to us for a little while. This is our contact information, and you guys have any questions, I'd love to answer them.
Thank you so much, Dr. Ware in Jamaica, for this great presentation. You're doing so much wonderful work for the families in your community and really connecting everybody, right? So I can't wait to see the final handoff protocol you come up with and how this pushback list continues to be pushed and grow and connect even more your community. So before we move to the Q&A, and a reminder, continue typing your questions. I wanted to promote our next webinar in our series, the Building Community Workforce Capacity to Equitably Support Chest Breastfeeding. So this webinar will be based on recommendation 5 of the blueprint that speaks to the need of training local public health, local allied health, and the local healthcare workforce to collectively support the community. So this will be on September 13, and you can pre-register today. And finally, here's some more of the continuing education credit information. Unfortunately, we are not able to share the link right now because we haven't been able to receive the final confirmation in the process to share those CERPs and CPUs, CME, CNEs, CHES, MCHES, CPH, and CUs, but don't worry, we will be sending them within the next week or so. So stay tuned for your email because we're going to share the recording of this webinar and 2 different links, one link for CERPs and CPUs and one link for the rest of the continuing education credits. So we're going to go now for the Q&A session. I hope you got a lot there's a lot of information shared. We talked about research on continuity of care and care continuity. Mommy talks about this whole implementation in DC wide with so many providers getting connected. And then you heard from our grantees, Dr. Ware and Jamaica, about this hospital to community handoffs. So we have some questions here. I'm going to ask everybody to come in. Also, if you do have resources that you're using, please share with us so we can upload to the blueprint, because then organizations that are trying to start this work don't need to reinvent the wheel to create like a MOU or to create a handoff flow or anything that you think it's related to this. Please send to us. We like to say here that sharing is caring. So share with us so we can share with others. So if all the speakers can come on, we're going to start with our Q&A session. And I already have a few questions here that I got. So the first one, I think it's actually for me because it's about the University of Chicago's work. They're asking, how is the University of Chicago Medical Center paying for the peer counselor after the grant is over? And that's a wonderful question. we ask that question ourselves from our grantees, sustainability, right? You got to start any grant thinking about sustainability. So they are actually piloting this position within the hospital. So right now it is mostly funded with our funds, but they already told me that they already secured additional funding because the project gained traction in the hospital. It is a quality improvement process, so they were able to secure additional funding to continue at least for a few more months after the grant is over, and they're collecting data and they're going to publish this. So hopefully they can get more funding this way. Hopefully, they're going to show how successful it is. But if the grant is for University of Chicago Medical Center is here, please feel free to type in more about this. And we hopefully we're going to have their whole full story when they complete the grant in the end of September, I think. The next question that I have here is for Linda. Linda, someone's asking, like, who pays for mommy services? I'm not sure if this is about the DC implementation or if it's overall, but can you talk a little bit about the DC maybe? And you're muted.
In DC, in the DC program, that was grant funded money that allows for specific care in that community for each patient in the specific districts that we work with. We do have some other grants around the country. Some of these services are provided through their Medicare or whatever services, insurance companies that allow for them to have support services connected, and using those providers use the Mommy platform to do all of that work. So we do have grant funded money, as well as some organizations, large enterprise companies, as well as smaller operating offices and businesses pay for a monthly service to use the platform for providing the education and support, messaging, articles, information guides, and also care coordination. So some of it is a fee for service for using the platform, and others is grant money.
Okay, thank you. There's another question for you, Linda. They are asking, using the definition of the warm handoff that we did the poll where the family is present, how are families present during the mommy online coordination of care other than the initial intake?
Well, our platform also has our own HIPAA secure video platform as well. We don't use Zoom. So we can actually get all of the providers on screen together and have everyone coordinating their care together. So we have the family, our nurse and or care coordinators, as well as the other providers that we connect the families with, if there is an actual provider. I mean, obviously, if we're sending someone to a organization such as a WIC office, we might not be able to get all of the care coordinators together on the screen, but we do have that ability to do that. All the providers who use the platform that have that feature can do everything through a virtual handoff. Remember, we're in another state, so we're actually doing a lot of things on our virtual platform, which is very successful.
Yeah, and just the fact that the clients, the families also have access to their own medical information, and they can see if everything is accurate there before transferring across providers. So I think this is really cool. Thank you so much. And I have a question for Dawana. So why do you think this consistency in care coordination are important for the families that you see?
So in my opinion, I feel like the consistency in care coordination is very important because, for example, once a family starts to, of course, connect with a person and they tell their story, and then, they kind of don't want to have to keep telling the story over and over again. So once they kind of grab hold of someone who actually shows the interest and the empathy and that they do care, it's just best that way. They may present with one, need, and then the other needs, of course, may come. So being able to actually handhold sometimes, it just kind of makes them feel, okay, they actually do care about my care. And then they're more, in a sense, likely to continue with all of the services that they are requested of.
Thank you so much, Dawana. You started touching in the last dimension, like I shared 3 dimensions of continuity of care, and that's the relational. One thing that we keep saying in our webinars is like, it doesn't matter how much you care until they know that it doesn't matter how much you know until they know how much you care.
Definitely.
So the relationship between providers and families. Thank you, and thank you for all the work that you do for those families that you serve. The next question here is for Dr. Ware. How did you find ways to help newborns come in for the first visit with the sound alarm?
Sorry about that. Yes, so that was really a very stressful time. Obviously, it was COVID, and realizing that our babies weren't getting in was so difficult for us as providers, as especially for the family. So we were able to do several things because we have the multidisciplinary group. So as Cincinnati Children's 3 different clinics, we have certain zip codes go to certain of the clinics, but we were able to, with the sound the alarm, push it up to the leadership and open up some slots for newborns at a different location within Cincinnati Children's. And then we were able to talk to the health commissioner for the entire county about the various health department clinics, one of which had closed altogether, and yet had a very large number of newborns and families who wanted to go there. And so he was able to help navigate that for us a little bit. So it was a push up to the leadership, because those of us down on the ground, we can see what's happening, but we aren't the decision makers. So we pushed it up to decision makers, and were able to get babies in quicker.
That's great. That's very, very important. Timely support. There's another question here for Jamaica, actually. How much staff time goes into your project? Like, how many full-time employees provide chest breastfeeding support in your community, or breast breastfeeding?
So specifically here on the FACS team, there's myself, and I am a 40-hour-a-week employee. We have a contractor that's up to 40-hour-a-week employee. We have 3 community breastfeeding advisors, and they give us about 3 hours a week. With our, which came with our mentorship, we have 3 CLCs that are going, well, they're taking their exam for their CLC. We also have another CLC scholarship. So hopefully in the end, we will have 4 CLCs, and we'll have 10 breast friends. So we'll have a pretty good team, and to have access to that mentorship, that exam for the CLC, that scholarship exam, and the scholarship for the breast friend training, they have to have basically a letter of commitment in how much they do community service, So if we are tabling at community events, like with WIC or something like that, there's an expectation that they come and do those things and lead support groups through Amen. So we have a pretty good team, a pretty voluptuous team, but I am the only 40-hour-a-week guaranteed employee that's doing this work.
Thank you, Jamaica. I have a question for both of you now, Jamaica and Julie, I think for the partnership. How are you currently processing warm referrals from the hospital to community organizations? And are you processing referrals for all the pushback list program?
I think I would say that's to be determined. Would you want to qualify that?
Yeah, I would say the same thing. It's definitely a work in progress. So that is like what we call like a big win. And then we're currently working on some smaller wins with WIC and our WIC peers, and having a little bit more of a warm handoff, but a little bit easier of a warm handoff. But as of right now, all of the providers, all of the hospitals have access to that Southwest Ohio Breastfeeding Coalition resource list and website, and they know that it exists, and we are definitely pushing for them to use it.
Thank you so much. Dr. Ware, I think someone is asking about the case study that you shared. Can you tell what happened with the baby in the case study? We're all curious.
Yes, I was leaving you all hanging on purpose. So I think the biggest answer from you all was 2 days and then 1 day. So that baby had so many risk factors, and the delivery and the mother, we would recommend that following day should have been the correct answer, which actually was when the baby went back in. But the outcome was that the feeding plan was set up for the mother and family and wasn't followed. So he actually did have to get readmitted. He's fine, but it was a hiccup, even despite handoff and follow up. There was some miscommunication, which we can think about that more, that the plan wasn't followed. So he is doing fine though. Mom and baby are doing fine, but thanks for asking.
Thank you, Dr. Ware. The question here for Dawana: how many people are attending the breastfeeding evening meetings?
So the way our support works is, what we like to do is ensure that we're able to meet our families where they are. So for example, DC is divided into 8 wards. So if a family lives in Ward 1, we were trying to make sure that we provide them with a resource that's located in their area. Or we do work with a app called Pacify, where they're able to receive the breastfeeding and lactation support right then on hand without leaving their home. So it pretty much just depends on what their preference is.
Okay, thank you, Dawana. And so just to close us here, there's this question, and we talked about so many things. So recommendation 3 alone has 8 strategies, and each strategy, as you see, is like so comprehensive. So I wanted to hear from all of you. For a person that is just now, organization that is just now starting to think about care continuity, care accountability, referrals, transfer of care, and all that involves relationship building and partnerships, what would be your one recommendation, like where to start? So let's start with Linda. You're on mute, Linda.
Trying to keep myself on mute so I can pay attention and listen. Where to start is it's a big answer. One of the things that we know, all of us know, we've all worked very hard at building relationships, not only in medical centers, in physicians' offices, but in the community as well. I think if we could all find someone to connect with and have that relationship built first, then from that will come all of the different parts of the handoff. If you don't know what's out there, you don't know to refer to them. If you don't know the rules, for example, like what the physician was saying about when a baby should be seen again, or who should be the one seeing the baby, that makes it very difficult for care continuity. So if we all have a way of reaching out and finding someone in our community to connect with, and then building that ecosystem and then base, that's actually how I believe that's how care coordination starts. And that's how anybody who's trying to build in their community have to step outside your door and find everyone in your community who's like-minded, doing what you're doing, and wants to see more of what you're doing happen.
Thank you, Linda. That was great. I love the ecosystem. We use that word here a lot too. And Dawana, your 2 cents.
Yes, I would definitely have to say I'm really connecting with individuals who really understand the population or target area, what that exact need is. It's, in a sense, it's a difference between, of course, we read about it, we hear about it, but sometimes actually having people who actually have a foot on the ground to actually see what the need is, I feel like it would make a big difference.
Oh, amen. That's great. And Dr. Ware?
I kind of ditto what you all have said, having that team, having that support team, having Jamaica on my team, and the community with the hospital. We can't, any of us, do it alone. We have to all do it together.
Thank you. And Jamaica, matching the color of the webinar with your yellow glasses.
Yeah, I mean, everything that everyone else has said, I think I would just tweak it a little bit of asking your parents, asking the patients, like, what is the need. I think that we love to bring folks to the table that are at these organizations, that are at these resources, and we just kind of talk about, like, of course, these are like the social determinants of health, these are breastfeeding, these are all the things that our community needs, but realize that our community members, the people that are living and breathing in these communities, definitely need to be heard. I think that was one of the best things that when we pushed out our surveys of where are the spaces that are breastfeeding friendly? What do you consider breastfeeding friendly? We asked moms and dads when we got feedback. And I think that's a perfect place to start.
Thank you. Thank you so much, Jamaica. Like your words of wisdom from all of you. Excellent. Thank you so much. We do have extra questions here, but about data, but I want to just say that we're going to have a webinar just on local data. So stay tuned. Thank you so much. We're going to be closing the webinar now. It's 2:30. Thank you so much for all the participants that stayed with us until the very end. Wait for our email with the recording and the links to continue education. And thank you for our amazing panelists. Thank you so much for helping us spread the word about care coordination. Thank you for all you do. Have a good afternoon, everyone.
Thank you so much.
Thank you.